Okay, so if something is very difficult to swallow, or if you end up coughing or choking after you eat, you want to think of an oropharyngeal dysphagia. And if something feels like you have a sensation of food getting stuck after you swallow, this is esophageal dysphagia. Now, right off the bat, if you have esophageal dysphagia to both solids and liquids, you want to think about more of a motility disorder. And if you have progressive, or if it's some sort of intermittent symptom of dysphagia, you want to think of an underlying condition causing it. Usually when something is intermittent, you want to think about esophageal spasm. And if it's a progressive problem, you want to think of achalasia. So if you have a hard time swallowing solids, you want to kind of think about mechanical obstruction. And if things are really progressive, like from solids, and then you eventually can't even drink liquids, you definitely want to think about a stricture or maybe even cancer. And again, that really big buzzword for cancer is weight loss. Now I think it's time to talk about eosinophilic esophagitis. And you really see this in younger men, 20 to 30 years old. And a lot of these patients have eczema or asthma, and these are atopic conditions. And a lot of these people have really tough time swallowing food, but you have to remember that it's intermittent, and they also have extensive eosinophilic infiltration of the mucosa. Sometimes they'll have chest pain, sometimes they'll even have refractory GERD. Now you really want to recognize this early for your patients because it can lead to fibrosis, and then you'll have strictures, and just like I talked about earlier, you can have difficulty swallowing solids, and then you'll have food impaction. Treatment usually is diet, proton pump inhibitors, or topical glucocorticoids like fluticasone or budesonide. And remember that the diagnosis is through endoscopy and esophageal biopsy. And of course, you will see eosinophils. If they were to describe the histology, they would see whitish exudates and ring-like esophageal indentations. We call this trachealization of the esophagus. I mentioned earlier about achalasia. This is just degeneration of the myenteric plexus, and the lower esophageal sphincter really can't relax. And again, dysphagia is progressive rather than intermittent. Remember, I mentioned earlier that eosinophilic esophagitis is really a patient in their 20s to 30s. You really don't see esophageal cancer in this population. It's pretty slowly progressive, and symptoms for the cancer are very progressive. They don't happen intermittently. Now, if you have a patient who has a lot of pain or odynophagia when they're eating, and they have like some sort of chest pain, and they have fever, and let's say that they are IV drug user, you really want to think about herpes esophagitis. They may even have oral ulcerations. This is something that I always forgot during step studying, so herpes esophagitis, don't forget that. Remember that difficulty swallowing, like they're choking after they're eating, but the food sensation is not there. This is again oropharyngeal dysphagia, and you want to think about myasthenia gravis. In this condition, you basically have fatigued bulbar muscles. Now, if someone has dysphagia and they're taking a lot of medications, don't forget that pill esophagitis should be on your differential. But a huge giveaway, at least clinically, for pill esophagitis is that they have an extreme amount of pain when they're swallowing.